Welcome back to the deep dive. Today, we are undertaking a really fascinating deep dive into a field that feels almost space-age sometimes, but it's very hands-on, gastrointestinal endoscopy.
It really is quite revolutionary, isn't it? I mean, you have to remember what we're dealing with, the GI tract. It's traditionally almost impossible to get a good look inside.
Right. It's incredibly long, complex.
Exactly, maybe 9 meters long,
Huh.
winding. And it houses this huge interface with the outside world, antigenically speaking, the body's largest immune organ, really.
So for centuries, doctors were basically working blind when it came to the gut.
Pretty much, which is why endoscopy wasn't just another tool. It fundamentally changed how we diagnose and increasingly how we treat things, a real paradigm shift.
Absolutely. So our mission today is, well, comprehensive. If you're prepping for exams, maybe facing a tricky case, or just want to really nail the fundamentals of GI endoscopy, we're digging right into the key stuff.
We essentially pulled out the core learning objectives and the meat from Chapter 9 of Bailey and Love's Short Practice of Surgery.
Consider this your focused revision session. We want you to walk away feeling confident about this whole area.
Yeah, we're aiming to cover, 7 key areas. First, the dual role, right? Diagnostic and therapeutic. Then, how a modern unit is set up, the gear, the people.
Consent and sedation safety, huge topics.
Crucial. Then managing those higher risk patients, diabetics, people on blood thinners, and of course the main procedures, OGD, colonoscopy, ERCP, EUS, what they're for.
Can't forget complications, recognizing and managing them.
Definitely not. And finally, we'll touch on some of the newer techniques, the really cutting-edge stuff for the small bowel and advanced imaging.
Okay, let's start with the history, because honestly, the problems facing the pioneers seem immense. Bailey and Love points out 2 massive hurdles.
Yeah, first, just the sheer length and twisty nature of the GI tract. How do you navigate that?
And second, it's dark in there. No natural light.
Exactly. So the solution needed some pretty radical thinking. The first glimmer, theoretically, was back in the late 1920s. This idea that you could transmit images through flexible quartz fibers, bend light around corners.
But an idea is one thing. Building a usable medical tool
Took decades. Quartz is fragile, making it flexible, steerable, robust enough. That was the engineering challenge.
And then we get these key figures, Hopkins, right? Harold Horace Hopkins. He figured out the optics, the flexible fiber imaging model, around 1954.
Yeah, he laid the groundwork. But the actual first flexible fiber optic gastroscope, that was Larry Curtis and Basil Hershowitz in 1958. That must have been incredible, suddenly being able to see inside the stomach reliably.
A whole new diagnostic world opens up.
It did. But what's really striking, looking at the timeline and the source, is how quickly people started thinking therapeutically. It wasn't just about looking.
Oh, right, like the polypectomy example.
Exactly. Colonoscopic polypectomy pops up in 1969. That's only about 11 years after the first scope. ERCP followed not long after.
And it just kept going.
Right up to now. Think about self-expanding metal stents in the mid-90s, huge for palliating cancer blockages. Or microscopy in 2008, letting us see almost at a cellular level during the procedure.
That pace is amazing. But the scopes we use today aren't mostly fiber optic anymore, are they? They're digital,
Yeah.
CCDs.
That's right. The shift to the charge-coupled device, the CCD chip, in the 1980s was another massive leap.
Why was that so significant clinically? Better pictures?
Better pictures, yes, definitely higher resolution than the old fiber bundles. But the key thing was the digital signal. It could be processed by a computer.
So that means?
It meant you could display the image on a monitor for everyone, trainees, nurses to see, huge for teaching. It meant easy electronic documentation, saving images. And critically, it paved the way for all the advanced image enhancement techniques we have now.
Which brings us to the modern era. High-definition, digital chromoendoscopy, using things like EUS endoscopic ultrasound to see through the wall.
Exactly. The lines are blurring, you know. The modern endoscopist needs skills from medicine, surgery, radiology. It's incredibly multifaceted.
And that complexity must make the organization and governance of the unit absolutely critical. It's not just about having a skilled operator anymore.
You absolutely need robust systems. Good hands aren't enough when the procedures get this complex and the patients are often sicker.
So speaking of systems, what are the non-negotiables for a well-run unit beyond the scopes and the room itself?
It really starts with the team. You need dedicated, highly trained endoscopy nurses, they're vital, and good admin support too. Then there's the whole layer of clinical governance,
Hmm.
meaning structured training, proper supervision, and objective assessment of competency. Bailey and Love mentions things like DOPS, direct observation of practical skills, plus reviewing logbooks, making sure people are actually getting the experience.
Right, so it's not just see one, do one, teach one anymore.
Definitely not. And performance has to be measured. That's where KPIs come in, key performance indicators.
Okay, KPIs. What are the really important ones units need to track for quality?
For colonoscopy, the big ones are completion rate, actually reaching the cecum, and the polyp detection rate. Even more specific is the adenoma detection rate, or ADR.
Why is ADR so crucial?
Because finding and removing adenomas, the precancerous polyps, is the whole point of screening colonoscopy. Higher ADR directly correlates with lower rates of interval cancer later on. It's probably the single best measure of how effective an endoscopist is at cancer prevention.
Makes sense. What other KPIs?
Things like mean sedation dosage that speaks to safety, and of course, tracking complication rates rigorously. Organizations like JG in the UK use all this data to certify units and individuals.
Okay, let's talk hardware. What's a basic kit list for a standard unit?
Your workhorses are the forward-viewing gastroscope and colonoscopes, usually adult and pediatric sizes. But you also need specialized scopes, like side-viewing duodenoscopes for ERCP, and maybe forward-viewing enteroscopes for looking into the first part of the small bowel.
And bigger centers need more.
Oh yeah. Larger, more specialized centers will have the full range. Linear and radial EUS scopes for ultrasound, capsule endoscopy systems, maybe single or double balloon enteroscopes for the deep small bowel.
And for actually doing things therapeutically, cutting, stopping bleeding.
The core is the electrosurgical unit diathermy for cutting and coagulation, but you need more fine tools too.
Such as?
Argon plasma coagulation, APC. It uses this jet of ionized argon gas to deliver a superficial burn. Great for things like bleeding angioectasias because the depth is controlled, less risk of going too deep.
Yeah.
And then maybe laser units or radiofrequency ablation, RFA, especially for treating larger areas like Barrett's esophagus.
Okay, this brings us to a really critical safety point.
Mm-hmm.
Cleaning the scopes. Decontamination. Why can't we just autoclave them like surgical instruments?
They just wouldn't survive it. The heat, the steam pressure.
Yeah.
It would destroy the delicate optics, the electronics, the polymers they're made of. Autoclaving is out.
So what's the alternative?
High-level chemical disinfection. And increasingly, the push is towards using disposable, single-use accessories, biopsy forceps, snares wherever possible to completely eliminate cross-contamination risk.
The source mentions 2 absolutely essential stages for decontamination.
Yeah.
Get the first one wrong and the second is useless.
That's right. Stage 1, which sounds basic but is vital and sometimes rushed, is physical removal of debris. Meticulous brushing of all the channels inside and out, flushing them thoroughly right after the procedure.
Why is that so critical?
Because if you leave behind blood, mucus, tissue fragments, it creates a biofilm. It physically shields any bacteria or viruses underneath.
Like a protective layer.
Exactly. The chemicals in stage 2 simply can't reach the bugs if they're covered in gunk. So stage 1, clean it meticulously until it's visibly spotless.
In stage 2.
Stage 2 is the chemical neutralization, immersing the clean scope in a validated high-level disinfectant for the correct amount of time at the right temperature, following the protocols to the letter.
Are there specific bugs or situations that need extra special attention?
2 stand out. First, duodenoscopes, the side viewers for ERCP. They have these incredibly complex elevator mechanisms at the tip that are notoriously difficult to clean. There have been documented outbreaks of multi-resistant bacteria transmitted this way. They need enhanced cleaning protocols, sometimes even double disinfection.
Okay, that's worrying. What's the second one?
Prion diseases, specifically variant CJD. The risk of transmission via endoscopy is thought to be extremely low, vanishingly small, really.
What?
But the guidance, especially in the UK, is still very cautious. If you do a procedure that's considered highly invasive, meaning you breach the gut lining with an instrument that isn't sheathed, like taking a biopsy on someone known or suspected to have VCJD, that specific endoscope has to be quarantined afterwards, effectively taken out of service.
Wow, okay, so decontamination is absolutely paramount. Let's shift now to the patient interaction side, starting with probably the cornerstone of safe and ethical practice, informed consent.
Absolutely fundamental. It's not just about avoiding lawsuits, though. Bailey and Love notes about 1% of U.S. negligence claims relate to endoscopy, often due to poor explanation. It's about patient autonomy.
So what does the patient really need to understand?
It's a conversation. They need to grasp the nature of the procedure. What are we actually going to do? The purpose, why are we doing it? The expected benefits. What are the viable alternatives? Maybe imaging, maybe medication, and crucially, the risks.
Talking about risks, you can't list every tiny possibility, can you? That would just terrify people. Is there a threshold?
There is. Generally accepted guidelines suggest you absolutely must discuss minor adverse events if the risk is over about 10%, and critically, any serious adverse event with an incidence greater than 0.5% or 1 in 200.
Why 0.5%?
Because that's considered frequent enough that a reasonable person would want to factor it into their decision. It's not a vanishingly rare event anymore. It's a tangible procedural hazard.
Okay, so what falls into that serious must discusses category? Let's list the key ones from Summary Box 9.2.
All right. General risks first. Complications related to the sedation itself, breathing problems, aspiration. Damage to teeth isn't uncommon. Then, procedure-specific risks. Perforation making a hole in the gut wall or significant hemorrhage, bleeding.
Especially after doing something therapeutic.
Yes, particularly after things like polypectomy, cutting the sphincter muscle during ERCP, sphincterotomy, complex resections like EMR or ESD, or putting in a feeding tube, PEG. Those carry higher bleeding and perforation risks.
And ERCP has its own specific list, doesn't it?
It does. For ERCP, you have to explicitly mention the big four. Pancreatitis, infection ascending up the bile ducts, cholangitis or sepsis, bleeding after sphincterotomy, and perforation of the duodenum.
Okay, that leads perfectly into safe sedation. The goal is usually conscious sedation, right? Comfortable, maybe a bit drowsy, but responsive, not a full general anesthetic for most diagnostic stuff.
Correct. For most diagnostic OGDs and colonoscopies, conscious sedation is the standard. The patient is relaxed, cooperative, but maintains their own airway and reflexes.
But it's not without risk. Bailey and Love points to the single biggest cause of death related to endoscopy. What is it, and how do we prevent it?
The most significant risk, the biggest cause of mortality, is medication-induced respiratory depression. Over-sedation, basically. Especially dangerous in frail, elderly patients or those with existing heart or lung problems.
And prevention is all about
Strict protocols. Having secure IV access before you start, careful, slow titration of the drugs, and continuous, vigilant monitoring.
Let's talk drugs. Usually benzodiazepine plus an opiate. How do we use them safely together?
Yes, typically a short-acting benzo like midazolam combined with an opiate like fentanyl or pethidine. The key is they potentiate each other. They have a synergistic effect.
Meaning you need less of each.
Exactly. You should generally give the opiate first, wait a bit, see the effect, and then give a reduced dose of the benzodiazepine. And you absolutely must remember the time course. Midazolam, for instance, doesn't peak for maybe 9 to 20 minutes. You can't just keep pushing it quickly.
So patience is key during induction. What about monitoring during the procedure?
Mandatory. Every sedated patient must have supplementary oxygen, usually via nasal specs. Continuous pulse oximetry to monitor oxygen saturation is essential. And critically, you need a trained assistant, usually a nurse, whose only job during the sedation is to monitor the patient's vital signs, responsiveness, and comfort. They can't be doing anything else. The endoscopist needs to focus on the scope.
Right. And after the procedure, what's the key advice driven by the drugs used?
The half-life. Benzodiazepines can hang around for a while. Midazolam's effect might wear off, but it could still be in the system, impairing judgment, for 4 to 24 hours.
So even if they feel okay?
They're not safe to make important decisions, operate machinery, or drive. Strict advice: no driving, no alcohol, no signing legal documents for 24 hours. And they absolutely must have a responsible adult to escort them home and stay with them. You can't just discharge them to a taxi.
Very clear. Okay, let's tackle those specific high-risk patient groups. Diabetes first. Why the rule about putting diabetic patients first on the morning list?
It's all about managing their blood sugar safely. They've usually had to fast for the bowel prep or the procedure itself.
Risk of hypo.
Big risk of hypoglycemia, yeah. Putting them first minimizes that fasting time. They can get the procedure done, get back to their normal medication schedule, and eat relatively quickly afterwards.
Does it matter what type of diabetes or how complex their control is?
It does. Someone on simple tablets is different from someone on complex insulin regimens or an insulin pump. For those more complex cases, you really should be liaising with their diabetes specialist team beforehand to get a clear management plan for the peri-procedural period.
Makes sense. Now, antibiotics.
Yeah.
You mentioned generally not routine, but sometimes needed. What are the clear indications for prophylactic antibiotics?
Okay, 3 main scenarios according to the source. First, peg insertion, putting in a feeding tube. There's a high risk of infection at the stoma site from skin bacteria being pushed in. Standard practice is a single IV dose of something like coamoxiclav just before. Manipulating an obstructed biliary tree during ERCP if you're not certain you can achieve complete drainage. If infected bile is left stagnant under pressure, sepsis is almost guaranteed, so antibiotics are needed there.
And third,
EUS-guided aspiration of cystic lesions, especially pancreatic pseudocysts. You're sticking a needle into a fluid collection, you don't want to introduce infection, antibiotics cover that risk.
what about the heart risk? I remember hearing about antibiotic cover for people with valve replacements.
Yeah, that's changed significantly. For
Yeah.
years, patients with prosthetic valves or a history of endocarditis got antibiotics before almost any endoscopy. But guidelines, certainly in the UK since around 2009, shifted.
Why?
Studies showed the actual risk of endocarditis after endoscopy is incredibly low, lower than after, say, brushing your teeth. So for most standard diagnostic procedures, routine prophylaxis for cardiac risk isn't recommended anymore.
Interesting shift. Okay, really tricky one. Anticoagulation. Managing patients on blood thinners. It's a balancing act, isn't it?
It's a classic clinical trilemma. You've got the risk of the procedure causing bleeding, the risk of the patient having a clot, like a stroke or a PE if you stop their anticoagulation, and the inherent bleeding risk of the procedure itself.
How do we start? What about common things like aspirin or NSAIDs?
Good news there, mostly. For standard doses of aspirin and most NSAIDs, the evidence suggests they don't significantly increase bleeding risk for low-risk endoscopic procedures. So, generally, they are continued.
What about for really high-risk procedures like ESD?
For things like ESD, where the bleeding risk is substantial, you might consider stopping aspirin, but it's usually continued for most standard therapeutic work like polypectomy.
What if someone comes in actively bleeding, an emergency,
Yeah.
and they're on warfarin? Do you have to reverse them completely before you can scope them?
Usually completely, no. If their INR is very high and you need to do therapy, inject something, apply clips, you need some clotting ability. The goal is usually to correct the INR down to around 1.5, maybe using vitamin K or clotting factors,
Why not normalize it completely?
because you risk causing a major thrombotic event if you fully reverse them suddenly. Get the INR low enough to allow safe endoscopic treatment, achieve hemostasis, and then you can often restart the warfarin safely, maybe even 24 hours later.
Okay, that's emergencies. Now for planned elective procedures. This is where the procedure risk classification comes in.
Exactly. You have to categorize the procedure itself as either low risk or high risk for bleeding.
Give us examples of low risk.
Low risk would be things like straightforward diagnostic OGD or colonoscopy, maybe an EUS just for imaging without biopsies, or an ERCP where you're just looking, or maybe putting in a stent but not cutting the sphincter.
And for those low-risk procedures, what do you do with warfarin or the newer DOACs?
Often you can just continue them, or maybe just omit the dose on the morning of the procedure itself. The bleeding risk is considered negligible.
Right. Now, the high-risk procedures, what defines those?
These are the ones where you're cutting tissue significantly, or the consequences of bleeding would be severe. So definitely polypectomy, especially large ones. Endoscopic sphincterotomy during ERCP, EMR, ESD, putting in a peg tube, or doing EUS-guided biopsies, FNA.
And for these high-risk procedures, stopping the anticoagulant is necessary.
Yes, temporary cessation is required, but how you stop and whether you need bridging therapy depends entirely on the patient's underlying reason for being on anticoagulation.
So you need to know their individual thromboembolic risk.
Absolutely. You look at Table 9.3 in the source. Does the patient have a low-risk condition, maybe simple atrial fibrillation with no prior stroke, or do they have a high-risk condition?
Like what? What constitutes high risk?
Things like a mechanical mitral valve replacement, AF, combined with a previous stroke, or TIA, maybe multiple prosthetic valves, or recent VTE. These patients are at high risk of clotting if their anticoagulation is interrupted.
So for a high-risk patient needing a high-risk procedure like a large polypectomy, what's the protocol? You can't just stop their warfarin.
No, you need bridging therapy, typically with low molecular weight heparin, LMWH.
Walk us through that bridging process. It sounds complex.
It is precise. Let's say for warfarin. Stop the warfarin about 5 days before the procedure. Start therapeutic dose LMWH injections usually 2 days after stopping warfarin, so there's overlap as the INR falls. Continue LMWH up until the day before the procedure. Omit LMWH on the day of the procedure itself.
Okay.
Then, assuming the procedure goes well with no major bleeding, you can usually restart the LMWH that evening or the next morning and restart the warfarin that evening too. You continue both the LMWH and warfarin until the INR gets back into the therapeutic range, which might take several days. Then you stop the LMWH.
Wow. That requires meticulous planning and patient understanding.
It absolutely does. Clear instructions, patient compliance, and good communication between the endoscopy unit, the patient, and whoever manages their anticoagulation normally.
Okay, let's move up the track to OGD, esophago-gastroduodenoscopy. The bread and butter upper GI scope covers esophagus, stomach, duodenum down to the second part. Technically, what's the one maneuver essential for a complete stomach exam?
It has to be retroversion, turning the scope tip back on itself when you're in the main body of the stomach.
Why is that so important?
Because if you don't retrovert, you create blind spots. You'll completely miss the gastric cardia where the esophagus joins the stomach and the fundus, the very top part. Significant pathology, including cancers, can hide there. Mastering retroflexion is key to a quality OGD.
Diagnostically, OGD is obviously vital if someone has alarm symptoms, trouble swallowing, weight loss, anemia. But Bailey and Love brings up this debate about open access OGDs being overused.
Yes, there's a real push towards more rational investigation, especially for younger patients with simple dyspepsia or reflux symptoms without any alarm features.
So instead of scoping everyone,
The guidelines increasingly recommend trying empirical acid suppression first, and importantly, doing non-invasive tests for H. pylori, the breath test, or stool antigen test. Treat H. pylori if it's positive. Only if symptoms persist despite these measures should you then proceed to OGD in that low-risk group. It's about being more selective, saving endoscopy for when it's really needed.
it makes sense for efficiency and cost, but OGD is also crucial for surveillance in some groups, right?
Oh, absolutely. High-risk groups like patients with Barrett's esophagus or certain inherited conditions like FAP, familial adenomatous polyposis, need regular scheduled OGDs to look for early signs of cancer development.
Okay, let's talk therapeutics, starting with emergency bleeding. How have we changed our approach to bleeding varices, and what's the standard now for a bleeding peptic ulcer?
For esophageal varices, those swollen veins, usually from liver disease band ligation, is now the standard. We used to inject sclerosing agents, but banding is safer, more effective, and has fewer complications like ulceration or strictures.
And for gastric varices?
Gastric or duodenal varices are often treated with injection of thrombin-based tissue glues.
And the bleeding peptic ulcer?
The standard of care is dual therapy. You inject adrenaline first to cause temporary vasoconstriction and slow the bleeding, but adrenaline alone isn't enough. The vessel can reopen. So you must follow it with a second definitive hemostatic method.
Like what?
Either applying endoclips to mechanically close the vessel, or using thermal coagulation like a heating probe or diathermy to seal it. Then, after successful endoscopic treatment, the patient needs high-dose IV proton pump inhibitors for 72 hours to reduce acid and promote healing.
What about more chronic, slower bleeding, like from angiectasias?
For those small superficial vascular lesions, argon plasma coagulation, APC, is excellent. Because it's a non-contact thermal method, the depth of burn is very controlled and superficial, minimizing the risk of perforation compared to direct contact probes. More recently, hemostatic powders or sprays have also become available for more diffuse bleeding.
Moving on to strictures narrowed areas, how do we open those up?
Usually with dilation, we can use balloons that go through the scope, TTS balloons. Or, for tougher strictures, guide wire-based bougies, like the Savory-Gilliard type. You pass a wire through the stricture first, then slide the dilators over the wire for safety.
And if dilation doesn't work or it's cancer?
Then stenting comes in. If it's a difficult benign stricture that keeps recurring, or more commonly a malignant stricture causing dysphagia, difficulty swallowing, we can place a self-expanding metal stent across it to hold it open and restore passage. It's mainly palliative in cancer.
Achalasia, that condition where the lower esophageal sphincter doesn't relax properly? Treatment has really evolved there, too.
It really has. Pneumatic balloon dilation, using a very large 30-40 millimeter balloon to forcibly stretch the sphincter, is still a common treatment.
But there's a newer endoscopic technique.
Yes. The big innovation is POEM, peroral endoscopic myotomy. This is highly specialized. Using endoscopic knives, the operator creates a tunnel within the wall of the esophagus, gets down to the muscle layer of the lower sphincter, and cuts the muscle fibers from the inside.
Wow. Like surgery, but through the mouth.
Essentially, yes. It offers similar results to surgical Heller myotomy, but without external incisions. It's a major advance. Botox injection into the sphincter is really only for frail patients unfit for dilation or POMN, as the effect is temporary, maybe 3 to 6 months.
Okay, let's pivot sideways now to ERCP, endoscopic retrograde cholangiopancreatography. What's unique about the scope, and how has ERCP's main purpose changed over time?
The scope is different. It's a side-viewing duodenoscope. You need that oblique view to properly see and cannulate the papilla of Vater, where the bile and pancreatic ducts enter the duodenum.
And its role.
It's shifted dramatically. Because ERCP carries significant risks, especially pancreatitis, its role as a purely diagnostic test is almost gone. Non-invasive imaging, particularly MRCP, magnetic resonance cholangiopancreatography, gives us excellent pictures of the ducts without the risks of ERCP.
So ERCP today is...
Almost exclusively therapeutic. We do it when we need to do something to the bile or pancreatic ducts.
Like what? What are the main therapeutic indications?
Primarily relieving biliary obstruction. Most commonly, that means dealing with gallstones stuck in the bile duct or treating strictures, narrowings.
How do you get stones out?
First, you usually need to perform a biliary sphincterotomy, making a cut in the muscle around the opening of the bile duct, using diathermy over a guide wire. This enlarges the opening. Then you can sweep the duct with retrieval balloons or wire baskets to pull the stones out.
What if the stones are huge?
If they're too big to pull out, you might need mechanical lithotripsy, crushing the stones within the duct using a special basket and wire system. If you still can't clear all the stones, you might place a temporary plastic stent to ensure drainage and plan another attempt later.
And for strictures, malignant ones.
For malignant biliary strictures, usually from pancreatic or bile duct cancer, placing a self-expanding metal stent, SEXMES, across the blockage is standard palliative care. It relieves jaundice and improves quality of life.
Does ERCP have uses in the pancreas itself?
Yes. We can use it to remove stones from the pancreatic duct, dilate pancreatic strictures, or sometimes drain pancreatic fluid collections, pseudocysts, by creating a tract into the stomach or duodenum.
There's a key safety tip for pancreatic ERCP work.
Absolutely. If you perform significant manipulation of the pancreatic duct, especially a pancreatic sphincterotomy, there's a high risk of causing pancreatitis afterwards. To reduce this risk, it's often recommended to place a small temporary pancreatic stent at the end of the procedure to ensure the pancreatic juice can drain freely. It usually falls out on its own after a few days.
Right, because ERCP complications are serious. Mortality around 1%. Remind us of those main specific risks again.
The big ones are pancreatitis, inflammation of the pancreas, the most common serious one, around 4.3% overall risk. Bleeding, especially after cutting the sphincter, 1.4%. Infection sepsis, cholangitis, if drainage is incomplete, can be up to 30% in some series. And duodenal perforation, making a hole near the papilla, about 1.3%.
That pancreatitis risk, 4.3%, it's significant. Are there known risk factors?
Yes. Table 9.5 lists them. Things like suspected sphincter of audio dysfunction, SOD, younger patient age, female sex, previous post-ERCP pancreatitis, difficult or prolonged cannulation attempts, injecting contrast into the pancreatic duct. These all increase the risk.
Given it's the most common serious complication, is there anything we can do to prevent post-ERCP pancreatitis?
Yes, there is strong evidence for one key intervention: giving the patient a rectal suppository of a nonsteroidal anti-inflammatory drug, NSAID, like indomethacin or diclofenac, either just before or immediately after the ERCP procedure.
How does that help?
The NSAID gets absorbed quickly rectally and inhibits the cyclooxygenase, COX, enzymes, damping down the inflammatory cascade that's thought to be triggered by manipulating the papilla and ducts. It significantly reduces the rate and severity of post-ERCP pancreatitis. It's become standard practice in many units.
Okay, let's venture into the territory that was hidden for so long.
Yeah.
The small bowel. 6 meters or so, tough to examine. What's the main reason we need to look in there now?
By far the most common indication is investigating obscure gastrointestinal bleeding. This means someone is losing blood, maybe iron-deficient anemia or passing blood, but their OGD and colonoscopy were both completely normal. The bleeding source must be hiding in the small bowel.
And why couldn't we just push a longer scope down before?
Standard push enteroscopy could only reach maybe 100 centimeters or so past the pylorus. The small bowel is just too long and loopy. Plus, it was uncomfortable, often needing deep sedation or even general anesthesia.
But technology came to the rescue.
Two major breakthroughs, really. First, capsule endoscopy, a diagnostic marvel. Second, device-assisted enteroscopy, like single or double balloon enteroscopy, which allows therapy.
Tell us about the capsule first. Swallow a pill cam, get pictures of the whole small bowel, no sedation needed. Sounds amazing, but there's a huge safety catch, isn't there?
Absolutely critical safety point. The capsule is purely diagnostic. It just takes pictures. It can't take biopsies or treat anything. More importantly, it's contraindicated if you suspect the patient might have a small bowel stricture or narrowing.
Why? What happens?
If the capsule gets stuck at a stricture, it causes an acute small bowel obstruction. That's a surgical emergency.
So how do you check if it's safe?
If there's any suspicion of a stricture, maybe the patient has known Crohn's disease or a history suggesting obstruction, you must perform a test beforehand using a patency capsule.
What's that?
It's a dummy capsule, the same size and shape, but made of material that will dissolve and pass harmlessly within about 40 hours if it gets stuck. You give the patient the patency capsule, maybe do an x-ray or use a detector to see if it passes. If it goes through okay, then it's safe to give the real video capsule. If it doesn't pass, you know there's a blockage and capsule endoscopy is out. You need a different approach.
Okay, so patency check first is any doubt. Now contrast the diagnostic capsule with balloon enteroscopy. This lets you potentially see and treat the whole small bowel. How does that work? It sounds like magic.
It's clever mechanics. You use a Lemming flexible enteroscope that goes through an overtube. Both the scope tip and the overtube have inflatable balloons. The technique involves advancing the scope deep into the bowel, then inflating the scope's balloon to anchor it. Then you advance the overtube down to the scope balloon, inflate the overtube's balloon to grip the bowel wall proximal to the scope. Now you deflate the scope balloon and gently pull back on the overtube.
What does pulling back do?
It pleats or gathers the small bowel over the enteroscope like pulling a curtain onto a rod. You shorten the segment you've passed through, then you repeat the process. Advance the scope further, inflate scope balloon, advance overtube, inflate overtube balloon, deflate scope balloon, pull back. It's the sequential accordioning process.
Allowing you to gradually work your way down or up.
Exactly. You can do it either orally, going down from the mouth, or anally, coming up from the rectum. Often, you might need both approaches on separate occasions to potentially examine the entire length and perform therapy like APC for bleeding lesions or biopsies.
Incredible technique. Okay, let's move to the other end. Colonoscopy. Reaching the cecum is the goal for a complete exam. What are the key skills needed to avoid that frustrating problem of looping the scope?
Looping is the enemy in colonoscopy, especially in the sigmoid and transverse colon, which are floppy. When the scope loops, pushing forward makes the tip actually pull back paradoxical movement.
So you get stuck.
Right. The core skills are 1. Using torque steering, twisting the scope shaft, combined with subtle insertion and withdrawal movements to guide the tip and prevent loops from forming in the first place. 2. Recognizing when a loop has formed and knowing how to reduce the loop by pulling back carefully, often while maintaining torque, to effectively shorten and straighten the colon over the scope. Abdominal pressure from an assistant can help too.
Are there tools to help with that?
Yes, some units use navigation systems like Scope Guide, which uses electromagnetic sensors to show a 3D image of the scope's shape inside the patient. It helps trainees visualize loops and learn how to overcome them. Using CO2 instead of air for insufflation also helps patient comfort post-procedure as it gets absorbed much faster.
Quality is huge in colonoscopy. Cecal intubation rate over 90%. But we mentioned ADR earlier, adenoma detection rate. Why is that the metric everyone focuses on?
Because it directly measures the effectiveness of the procedure in achieving its primary goal. Finding and removing precancerous polyps, adenomas. There's robust data showing that endoscopists with higher ADRs have patients who are significantly less likely to develop colorectal cancer later on.
How do you improve ADR? Just look harder.
Meticulous technique is key. But specifically, withdrawal time is crucial. You need to spend adequate time carefully inspecting the mucosa as you pull the scope back out. The general target is a minimum withdrawal time of 6 to 8 minutes in a normal screening colonoscopy. Rushing the withdrawal means you will miss polyps.
And technology helps here too. Image enhancement.
Definitely. We have traditional chromoendoscopy using dyes like indigo carmine sprayed onto the mucosa. It highlights the surface contours and pit patterns, making flat or subtle lesions easier to spot, especially helpful in colitis surveillance.
But the digital stuff is more common now, like NBI.
Yes, digital or virtual chromoendoscopy like narrowband imaging, NBI, or similar technologies, iScan, ICE, are built into most modern scopes.
Remind us how NBI works. What's it doing with the light?
NBI uses optical filters to illuminate the mucosa with only very specific narrow wavelengths of light, typically blue light around 415 millimeter and green light around 540 millimeters.
And why those colors?
Because blue light is strongly absorbed by hemoglobin in the superficial capillaries just under the surface. Green light penetrates a bit deeper and highlights the submucosal vessels. By enhancing the contrast of these vascular patterns and the fine mucosal structure, NBI helps the endoscopist differentiate between types of polyps in real time.
So you can potentially tell a harmless hyperplastic polyp from a precancerous adenoma just by looking at the pattern.
That's the goal optical diagnosis. It can help guide decisions about which polyps need removal or more detailed assessment.
Okay, let's talk removal. Polypectomy. Then the more advanced stuff, EMR and ESD. Start with basic polypectomy.
For small polyps, especially non-pedunculated, flat ones less than maybe 15 millimeter, cold snare polypectomy is increasingly common, just snaring it off without diathermy. For larger polyps, or those with a definite stalk pedunculated, hot snare polypectomy using diathermy current is standard. You need to be careful with settings to cut effectively, but also coagulate the feeding vessel in the stalk to prevent bleeding.
What if it does bleed?
You need measures ready. Injecting adrenaline into the base, applying clips across the stalk or defect, sometimes using a detachable nylon loop, endoloop, around the stalk before cutting.
Now, EMR endoscopic mucosal resection. When is this used and what's the crucial first step?
EMR is typically for larger flat or sessile polyps, maybe 10, 20 millimeters, sometimes bigger. The absolute key first step is submucosal injection.
Lifting the lesion.
Exactly. You inject a solution, often saline, sometimes mixed with adrenaline or a blue dye like methylene blue underneath the polyp. This lifts the lesion up off the deeper muscle layer, muscularis propria.
Creating a safety cushion.
Precisely. It makes snaring the lesion safer, significantly reducing the risk of deep thermal injury or perforation. After lifting it, you snare it off, often using diathermy. If the lesion is very large, 20 millimeters, you might remove it in multiple pieces. That's called piecemeal EMR, key EMR. Then you might ablate the edges to reduce recurrence.
Okay, so EMR lifts and snares. What about ESD endoscopic submucosal dissection? That sounds more complex.
It is significantly more complex and technically demanding. ESD is generally reserved for very large flat lesions or lesions suspected of being early cancers confined to the superficial layers.
How is it different from EMR?
Instead of just lifting and snaring, ESD involves using specialized endoscopic knives. First, you mark the margins around the lesion. Then you make a circumferential incision around the lesion, cutting down to the submucosa. Then you carefully dissect the lesion off the underlying submucosa, cutting the connecting fibers.
So you remove it in one single piece.
That's the goal on block resection, even for very large lesions.
Why go through that complexity compared to piecemeal EMR?
Two main reasons. First, getting the entire lesion out in one piece gives the pathologist the best possible specimen for accurate staging, checking the depth of invasion and whether the margins are clear. This is critical for suspected early cancers. Second, en-bloc resection with ESD has significantly lower rates of local recurrence compared to piecemeal EMR, especially for larger lesions.
Makes sense, but sounds like it takes a lot of skill and time.
It does. It's usually performed in specialized centers by highly trained endoscopists.
What else can we do therapeutically during colonoscopy?
Similar things to OGD, really. Using APC for bleeding angiectasias, dilating benign strictures, often at surgical anastomosis sites, usually with TTS balloons, and placing self-expanding metal stents, SES, for palliation of malignant colonic obstruction, often as a bridge to surgery or for patients unfit for surgery.
Okay, let's touch on colonoscopy complications again.
Yeah.
Perforation and bleeding are the main ones.
Yes. Overall perforation risk for diagnostic colonoscopy is very low, maybe 1 in 2,000. It increases with therapeutic procedures like polypectomy, maybe to 0.1% or 1 in 1,000. Risk factors include severe diverticulosis, active colitis, or previous pelvic surgery radiation. Hemorrhage risk after polypectomy is around 0.3%, and remember, it can be delayed, occurring up to 1-2 weeks later.
But there's that other important complication that mimics perforation.
Right, the post-polypectomy syndrome, sometimes called post-polypectomy electrocoagulation syndrome.
What is that exactly?
It's basically localized inflammation of the bowel wall and surrounding peritoneum caused by a deep thermal burn during polypectomy, but without an actual full-thickness hole. The electrical current goes deeper than intended.
So the patient presents like they have a perforation. pain, fever, tenderness.
Exactly. They get localized peritonitis. The crucial thing is to differentiate it from a true, frank perforation. Urgent clinical assessment is key, usually involving a CT scan of the abdomen. You're looking for signs of free air outside the bowel or significant fluid collections, which would indicate a definite perforation needing likely surgical repair. If there's just localized inflammation or wall thickening without free air, it's likely post-polypectomy syndrome.
And the management differs.
Hugely. Frank perforation usually needs urgent surgery. Post-polypectomy syndrome is typically managed conservatively with bowel arrest, IV fluids, and antibiotics. But you need that prompt assessment and often surgical consultation to make the right call quickly. Missing a true perforation is disastrous.
Okay, final area. Endoscopic ultrasound EUS. Why do we need this? What does it show us that regular endoscopy doesn't?
Conventional endoscopy, even with HD and NBI, only shows the surface, the mucosa. EUS adds the dimension of depth. It uses a high-frequency ultrasound transducer built into the tip of an endoscope.
So you put the ultrasound probe right against the gut wall.
Exactly. Or close to adjacent structures like the pancreas or lymph nodes. This gives incredibly detailed images of the layers within the gut wall itself, mucosa, submucosa, muscularis propria, serosa, and it shows surrounding structures, lymph nodes, blood vessels, pancreas, bile duct, with much higher resolution than external ultrasound or even CT MRI for nearby things.
Its main role historically was staging cancer.
Yes, it revolutionized the local staging, T-stage depth of invasion, and end-stage nodal involvement of esophageal, gastric, rectal, and pancreatic cancers. It's often the most accurate modality for determining how far a tumor has grown through the wall and whether nearby lymph nodes are involved. This information is critical for deciding on treatment surgery, chemotherapy, radiotherapy.
Are there different types of EUS scopes?
Broadly, two main types. The radial echo endoscope typically has the ultrasound transducer scanning in a 360-degree plane perpendicular to the scope shaft. It gives excellent cross-sectional images, great for visualizing the wall layers and assessing tumor depth, T-stage.
And the other type?
The linear echo endoscope. This scope usually has the ultrasound beam scanning in a plane parallel to the long axis of the scope. Crucially, linear scopes also have a working channel, like an ERCP scope.
Why is the working channel important with the linear scope?
Because the ultrasound image is aligned with the direction the instruments come out of the channel. This allows for real-time ultrasound-guided intervention, primarily fine needle aspiration, FNA, or biopsy.
So you can see a suspicious lymph node or a pancreatic mass on the ultrasound screen and guide a needle directly into it to get a sample.
Precisely. That's the power of linear EUS. It allows tissue diagnosis of lesions outside the gut lumen that are inaccessible to standard endoscopy.
So beyond cancer staging, what are other key uses for EUS, especially linear EUS?
Diagnosing subtle bile duct stones, microlithiasis that might be missed by MRCP, getting biopsies of submucosal lesions, lumps growing under the surface lining, draining pancreatic pseudocysts into the stomach or duodenum under ultrasound guidance, and even performing procedures like celiac plexus block, injecting anesthetic near the nerves behind the pancreas to control severe cancer pain.
It sounds like EUS procedures might be more involved.
They often are. The scopes are larger diameter, the procedures can take longer, and FNA requires precise maneuvering. So EUS often requires deeper sedation, sometimes even general anesthesia, especially for complex therapeutic interventions. #HAG outro. So pulling all this together, the overwhelming message from this deep dive into Bailey and Love's chapter is the enduring central role of endoscopy.
Yeah, despite all the amazing advances in radiology, CT, MRI, MRCP, and things like capsule endoscopy,
The ability to not just see with incredible detail, but to take targeted biopsies based on what you see, and then crucially, to intervene therapeutically, whether it's removing a polyp, stenting a blockage, stopping bleeding, doing EMR, ESD, or POEM, that combination keeps endoscopy absolutely vital in managing GI diseases.
it's constantly evolving, isn't it? You hear about AI assisting with polyp detection, now robotics. The field isn't standing still.
Not at all. It keeps pushing boundaries, blurring those lines between medicine, surgery, and radiology even further.
So for you, listening to this, maybe revising or preparing for practice, what's the single most important takeaway message?
I think it comes back to the fundamentals. As the procedures themselves get more technologically advanced, and as we treat older, sicker patients with more complex issues like anticoagulation or multiple health problems.
The basics become even more important.
Exactly. Mastery of endoscopy isn't just about slick scope handling. It's fundamentally about meticulous patient care. Thorough pre-procedure assessment and planning, crystal clear communication during consent, strict adherence to safety protocols like decontamination and safe sedation, and commitment to quality improvement through things like monitoring ADR.
Get the basics right every single time.
That's where true competence lies. The success or failure of an endoscopic procedure is often determined long before the scope even touches the patient.
Okay, let's end with a provocative thought for you to mull over. We talked about these incredible, minimally invasive endoscopic therapies like POEM for achalasia or ESD for removing large superficial cancerous procedures that are replacing traditional open or laparoscopic surgery in many cases.
Yeah, less invasive, faster recovery. Huge
Yeah.
benefits.
But these advanced endoscopic procedures, while less invasive overall, can have their own unique and sometimes complex complications. Maybe a contained perforation after ESD, or significant delayed bleeding. So here's the question. As endoscopy takes over more and more therapeutic territory from surgery, how do we ensure that surgical and gastroenterology training programs adapt quickly enough? How do we make sure the next generation of specialists are fully competent, not just in performing these amazing new procedures, but also in recognizing and expertly managing the potentially severe complications that arise specifically from them? It's a real challenge for medical education moving forward. Something to think about.